We are going to kind of transition over. Mr. Glover and Dr. Bentley will be leading the discussion. I'm going to put a couple questions here just to kind of get things going. And I believe we'll have a demonstration of the disability dashboard, which will be awesome too. Okay. All right. Thank you.
This is Brandie. Do we want to hold space for a moment for folks who may have questions before we start with the demonstration?
Yeah, I'll just give 1 second. Just to kind of kickstart things, I do have a question I just want to throw out there. I know we heard that representation really matters in a lot of what we do, whether it's research, clinic. I know one thing that is often overlooked that we heard earlier is really the caregiver burden, and also making sure that we recognize that they are part of the team. And Dr. Jensen, obviously clearly demonstrated the impact on them in terms of hours. So one thing is pitching a question here. I know Medicare and certain programs do allow sort of a small scale employment with home care agencies. Are there any models that maybe we can chat about? And then maybe we can also talk about models of hoping to increase the representation of people with disabilities in research and healthcare. And then if there's no other questions, we can go to the disability dashboard. That work? Okay. Dr. Jensen, Kara, would you like to kind of start things?
Yeah, sure. So, like you said, I think it's so important to understand the caregivers and to really center them as the care consumers because they are really a key component of the team. And we kept hearing that from caregivers of saying, one of the best things that providers can do is treat me like I'm a member of the team. And that goes too for older adults or older adolescents who have disabilities but can self-advocate. They are also part of the team. So I think it's really important to make them feel as such and empower them because as we've seen with medical technology improving, people with disabilities are living longer and healthier and happier lives, which is fantastic. So they need to be taught and scaffolded into being included in that conversation as well. Um, as far as the Medicaid, Medicare stuff, that is honestly a little bit outside of my grasp because it keeps changing so often. But we know that a lot of disabled people require and rely on Medicare and Medicaid to get their healthcare needs met. Um, so it is important to continue reaching out to your representatives and making your voices heard because a lot of people with disabilities or people that care for people with disabilities don't have the same level of time and energy to devote to advocating outside of their own home because, like we saw, many caregivers spend the majority of their time simply providing medical care for their children. So I think this is a good call to continue to advocate in the ways that we are able to. I don't know if anyone else wanted to speak to the Medicare Medicaid situation.
Yes. Well, back then I worked in a hospital and I worked in substance abuse. And little short story, we took Blue Cross, the hospital, and all our patients were mostly factory workers who had Blue Cross. They didn't come into the hospital from November to January because the holidays. So I said, let's take Medicaid patients because they don't care about the holiday. They don't have that stipulation about the holiday. They're kind of even. They kind of balked at me and balked at me. The people at the hospital balked at me, balked at me. And I figured out why. Because Blue Cross rate of reimbursement was 3 times as high as Medicaid. And every health insurance payer has a different rate of reimbursement. And I noticed in your presentation, Dr. Jensen, you mentioned that caregivers who had private insurance were more likely to be more stressed than people with on Medicaid. Is that is the reason is that is one of the reasons why people with private insurance are more likely to be denied a certain procedure, certain services? Is that the reason they might be feel more stressed?
Yeah, that did come up. Many caregivers felt like they had to fight harder
Mhm.
to get insurance to approve things. I had one caregiver share that they spent 80 hours in a single week fighting claims for their child to get a very medically necessary procedure
Right.
because they had private insurance. So yeah, that's a correct assumption.
Okay, I kind of figured that. And also, as far as being seen at the doctor, if a person has Medicaid, and it needs more time to be seen, that rate and reimbursement is going to be lower. So you don't want to spend a whole lot of time with a person uh, with Medicaid because you're in a clinic and you have your staff to pay, you have this to pay, you have that to pay, you got to pay yourself. I think I always kind of thought that's why people did not want to take, particularly our adults with disabilities and children with disabilities, because the level of care is more intense and time consuming. Are you finding that out in your?
Yeah, we definitely see on the caregiver side, that's their perception. I haven't heard any practitioners come out and say that. I think that's more of a administration
Yeah,
situation,
right.
which
Yeah, they're not going to
insurances.
say that. Yeah, but I think they're going to be encouraged by the administration.
Yeah,
You know,
because I mean, hospitals are a business,
right,
just like everything else. So
right,
unfortunately, it does come down to reimbursement rates and the amount of money that they can make off of a population.
right. Plus the level of care, because we have a population severely emotionally impaired kids, so they have a lot of complex medical. Some might have behavioral needs. Some might have sensory issues. So the care of that person will be time consuming at a doctor's visit. Uh, we have a school in Kaiden. We're always constantly advocating for these kids to get what they need in school. Sometimes that kid needs a nurse to do certain procedures. Like, give you an example, one kind kid has cerebral palsy, cognitive impairment, and needed tube feeding because of swallowing. And so it was the hardest thing to get this kid a nurse to do this, you know. And I didn't realize we finally did it, but I didn't think it took that much. It shouldn't have took that much advocating, and that much time and that much wrestling with the school to do something that needs to be done because it was obvious that this kid needed this, and they kind of fought us on it. So we finally got it done, and that's kind of what we do here at the ARC. Also, I noticed I go to other countries. Like I went to France, I went to Kazakhstan, and they treat disabilities different. With us, it's a constant fight because we have. If you go look through the years from 1973 to 504, and then to IDEA, to the American Disability Act, it's always a constant fight for us to get anything done. And I don't see that in other countries because I think they have more of an opportunity. Give you an example. I don't want to take too much time. Um, our kids with disabilities who play sports. I coach basketball, Special Olympics. I had some exceptional players. That's how I got recruited to do the national thing. The kids in the United States with disabilities who are my cognitive impairment or special education do not have an opportunity to play sports beyond, in high school because they're not allowed to play high school sports. In France, they have that pathway. Like one kid was just as good as my kid, and he's getting paid to play basketball, even though he has a cognitive disability, mild cognitive disability, just like one of my kids did. But he's getting paid. So my kid lived in France. He would be getting paid to play basketball because France doesn't have or all of Europe has a college system. They have a different types. They have a league system, so everybody can play. Regardless, they don't even that doesn't even come up. But I think we kind of learn something from other countries, and that we're always in a constant battle. And I don't know if you guys experience that, but I'm sure you do. Well, Kara Manor, I think she kind of laid out the battle that we're in. That's a constant fight for whatever, for rights to be looked at, to be seen. You kind of want to make people with disabilities kind of disappear, or they don't want to screw the numbers and by adding with people with disabilities. I kind of feel my own paranoia, but that's my feeling. I wonder, as Kara Manning, do you feel that? Are they not? The reason they want to exclude people with disabilities, they don't want to screw the numbers.
This is Kara. Yeah, I do think it is. There are so many kind of impulses to disappear, erase disabled people's issues. I think in the clinical context, Dr. Jensen talked about this as people just being uncomfortable, right? And I think so, when disabled people are advocating for different issues, right, we have an approach that says like through a disability lens we can build that allows us to build connection and relationship with other groups, right? So that we can like build coalition together. But I think when that gets turned around, and I don't necessarily think it's like I think it can be nefarious, but it isn't necessarily. When we sort of ask to be in coalition with others, it's an opportunity for them to say, well, this impacts so many groups, and we can just be in a laundry list without really attending to the specific needs of disabled people. And so I think there's always that tension there that we're working through and against, and it pops up in different places.
Yeah, I get kind of paranoid when with of the reasons why people with disabilities are so kind of like discriminated against. And I think it's like sometimes it's money, sometimes it's just don't want to be bothered, sometimes it's time, sometimes it's ignorance. They just don't know about people with disabilities. Also, at the medical front, we do have issues with the children. It's not so bad. They're used sometimes the doctors and nurses let the parents and social workers let the parents be a part of the treatment. Well, with adults, I feel like it's more of a challenge. I think one of them might be HIPAA because what they're talking about is private health information. They don't want to disclose anything. If you have like some people they have hired caregivers. That hired caregiver will take that person to the doctor, and the person who's cognitively impaired, he won't or she won't understand the procedure or the medication or whatever. And some doctors' offices share the information so that person can get that medication and administer it. Some of them don't. And when they don't, it can be a problem because that person cannot administer his own medication. So that's another issue we have to look at because it kind of works from doctor to doctor to clinic on how much information, how willingness they're willing to let that caregiver be part of the team. And that's important because some of our people are nonverbal, so they can't speak, or some of our people are verbal, but they're difficult to understand and they're difficult to communicate. But a caregiver who's with them for that person every day can help that person communicate with the doctor. Like I'm feeling this, I'm feeling that, or that person has a question. It kind of like translated, use any other word to the doctor, so that need can be met. And I think, like I said, some doctors are balk at it and don't want to give up, don't want to participate, and some doctors just go ahead and do it. Are you finding that, Dr. Jensen?
Yeah, I think there is some of that too. The self-determination piece. I see Dr. McKee has raised his hand.
Dr. Jensen, please answer the question. I just want to make sure we also have time to move on because
Oh,
we do
okay.
need to close at 10:30 and just to have a brief demonstration. Sorry to cut you off, Dr. Jensen. Please feel free to answer the question.
Oh, no problem at all. I think we are seeing some of that just in terms of caregivers feeling really under supported. And then as adults or adolescents grow into adults with disabilities, we saw that a lot of practitioners weren't trained to help that transition, which is so important to allow people who are able to self-determinate as much as possible. So yeah, I think there is some of that for sure. I do want to leave Dr. Bentley enough time to do the dashboard for us, so I'll turn it over to you for that.
Awesome. This is Brandie. Thank you all for that really insightful conversation. I also want to highlight that Dr. Benavides left a resource in the chat. She says that Medicare does not currently pay parent caregivers to deliver care, but Medicaid may, depending on the state, and put a link to additional resources for that. And so I will highlight that. It is in the Q&A section. Thank you. Okay, I've shared my screen so that we're able to see the dashboard. Mr. Glover, would you like to select the topics and the demographics that we use to demonstrate the dashboard?
Let's do you have a one for health measure of prostate cancer?
No, we don't have prostate cancer. We
Or
have
well, or,
cancer in general.
ever had cancer?
Ever had cancer? Got it.
Select their demographic, but with a cognitive disability,
Yes, we can do cognitive disability.
African American.
And I want to filter for race.
Yeah. Okay. God, there you go.
There we go. Do you want, we have 2016 through 2023, so we can look at all of the years.
Yeah, okay, perfect.
Okay. So across 2016 to 2023, it looks like 7.27% of Black individuals with cognitive disabilities reported ever being told that they have any type of cancer.
Okay. That's what I wanted to see. How that, how you can just look up something real quick. Because that kind of just gives us we can look at we can look at where the need is at and kind of advocate for it. And once we can like show this to whoever, like a policy hold maker, that we are looking to increase funding or increase awareness for a certain population, and this is why or why not we should do it. That's what I kind of wanted to see. Okay.
Yes, yes, this is Brandie. Absolutely. We have a number of health measures here, and as we launch additional data sets, we're trying to be very comprehensive in the things that we're presenting. So in the next upcoming launch, we also have measures that look at different social determinants of health. We have questions that look at number of ER visits, the quality of relationship between patients and caregivers. And so we're trying to diversify the metrics as much as possible so that folks can use this to advocate for different issues that are important to you and your communities.
Okay. Good. Like a routine checkup in the past year. Let's say as any race, or people with a cognitive disability and through all years.
Okay, we have all, and then we can look by just at cognitive. So
Okay.
75% of people with a cognitive disability report having visited a doctor for a routine checkup within the past year.
Okay.
I see another one in the chat, cardiovascular disease, heart disease among women with disabilities. Let's see.
Mm.
And all, okay. And so this shows the percentage of respondents that have ever reported having coronary heart disease or myocardial infarction, if I pronounce that correctly. And we
Mhm.
filtered it to look at differences across females and males. And this chart shows anybody with a disability. So it's exclusive only to individuals that report having a disability. And so for males with disabilities are reporting a higher prevalence of ever having heart disease compared to females. See, yep, and this is all years, 2016
Here.
to 2023. Mhm.
We have a question for Dr. McGee. When we talk about a checkup, visiting a doctor, routine checkup, yearly visit, does that include blood work?
This is Mike McKee. So that can vary. It's not an automatic requirement. Some of that really, it just depends on their age, the gender. I mean, a really sort of straightforward physical for younger adults does not always include it. But it's important that we understand that it's often driven by family history, personal risk factors. So it's really just an opportunity to kind of think about what you might need to think about from screening. Also think about your problem list. So it's just really more of a protected time to have a chat and then tackle all the screening, risk monitoring, and so forth. Yeah, but I would say most physicals do incorporate some laboratory monitoring though.
I know at certain ages they do screenings, and certain ages they stop doing screening. Is that true, Dr. McKay?
Yeah, so feel free to call me Mike. So in terms of the screenings, one I will probably just allude to is, we talked about the prostate cancer screening. That's incredibly messy and is one that often we have a doctor-patient discussion, and there are some pros and cons of it. It's not a perfect solution, so that's why you don't see very clear-cut recommendations to proceed with a PSA, which is a
Right.
prostate-specific antigen. So in terms of cardiovascular monitoring, I know a lot of people think of lipid management. So these are the cholesterol that we do. We also do screenings for like A1C, and in some cases we can include more like electrolytes, kidney function, liver function. But again, those are really driven by risk factors.
Yeah. Yeah. So I kind of reason I ask that because some of our members are getting older. We kind of like what screening should we now see them getting? Because a lot of times, we try like if you catch things early, it's very, very, very treatable. We'd rather have them catch it earlier than later so it can be treated. So we kind of like want to know what screenings to ask for. Because some of give you an example, if you have a member who's kind of disabilities living with his parents and he's 50 years old, you can do the math and tell how old his parents are. So we have a program called After I'm Gone to help the person
What
who,
do I'll share a link that I think would be useful for everybody. But one thing I just want to say before we move on and close for the break, I want to make sure we have time for the keynote speaker. People with disabilities, we have to understand that it seems clear cut that we do need to have more tailored screenings. So what we often do for general population misses a lot of the potential risk and disease management that we see often presenting in younger ages for people with disabilities. And that is why we need to go back to clinical training, why we need the dashboard, why we need research to understand what is different. And that precision medicine that we need with guidance with smart sets and electronic health records, better training. Hopefully, we can do a better job in addressing a lot of the health issues. So I'll put a link that might be useful in terms of screenings and recommendations. Yeah, we'll close for a break. And then India, let me make sure. Can we actually, why don't we, is everybody okay with a 10-minute break? And then we'll come back at 10:45. Does that work for everybody?
Yeah.
That sounds great.
All right, so we'll close and we'll just put a slide for a break and we'll see everybody back in a few. All right, thank you so much. Thank you, Dr. Bentley and Mr. Glover. Appreciate the very insightful discussion. And also really thank you so much for all the presenters this morning. I'm looking forward to our next step. Thank you.